Thank you all for joining this next session on combating misinformation. I'm Derek Rapp, Research America board member and a managing director at Rivervest Venture Partners, a biopharma and med tech venture capital firm. It's a pleasure to be here with you and to MC the next few sessions of the National Health Research Forum. Combating misinformation in science and helping society gain confidence in science have become important objectives of Research America and are key elements in the organization's strategic plan. On this next panel session will be Dr. Reed Tuckson, Managing Director, Tuckson Health Connections, Dr. Claire Wardle, co-founder and co-director of the Information Futures Lab and professor of the practice at Brown University, and Dr. Ross McKinney, Chief Scientific Officer, Association of American Medical Colleges. The panel will be moderated by Jenny Luray, Research America's Senior Vice President for Strategy and Public Engagement. You can find all of their bios in the document in the chat. Jenny, over to you.
Thank you so much, Derek. I'm going to ask the audience, do you hear an echo? If so, I'm going to ask our team to get that fixed. Somebody's coming in here to help with the echo right now. We're just going to take a quick pause so we can get this fixed.
Jenny, you sound fine to me.
Yeah.
I think the echo is local to you.
It's more gravitas for you that way.
All right, I think we've taken care of the echo. Thank you all for that pause. And thank you, Derek, for the introduction, and to our audience joining us near and far. Misinformation is certainly something of great concern to those of us in the scientific research advocacy community, but more than half of Americans are also very concerned about the impact of misinformation on public health, according to a 2023 survey commissioned by Research America. So today, we'll first take a holistic look at misinformation with our experts. What have we learned about it? What is it? And how has it changed over the course of the COVID pandemic? And then we'll talk about concrete approaches for scientists, health professionals, advocates, and others to most effectively deal with misinformation. We'll also have time for audience questions at the end, and you can enter those in the chat or the Q&A. So first, let's start with a definition of misinformation. And Ross, I'm going to throw that one to you.
Okay, well, misinformation, I think what we have is two levels. Misinformation is the provision of information that is inaccurate. So whether somebody knows it's inaccurate or doesn't know, it's simply information that isn't grounded well in facts. Disinformation, which is a kindred term, is the use of inaccurate information to achieve an end. So it's knowingly providing information that's inaccurate in order to achieve a political or economic end. And it's disinformation, I think, that worries us in many ways the most.
And disinformation can quickly turn into misinformation, right? As unsuspecting people spread that disinformation. So the two get quickly conflated. Claire or Reed, do you want to add to that definition?
Yeah, I'll happily add to it. I've done a lot of work around definitions in my research career. I mean, one thing that I increasingly struggle with, because the dichotomy works, we get asked these questions in these panels and, Ross is absolutely right. But I spend a lot of time in anti-vax communities with people who really believe that they are preventing harm. They spend all day reading scientific journals. They're just coming to different conclusions to us. But if you say, are they trying to, some of them are trying to sell supplements, but a lot of them are deep in these communities trying to prevent harm. They have fallen into a space that they believe that vaccines cause harm. So I think sometimes when we think about these definitions, there is a lot more gray area than we need to consider. And how do we reach people who in many ways really believe that they're doing the right thing for their families and their communities? And I think that's the challenge we have as researchers and clinicians as we move forward.
Thanks, Claire. And we'll be talking more about that. Reid, do you want to jump in on the definitional issue?
I guess they've done such a great job. I think there's another category that we probably should put in there, and that's the category of rumors. So rumors being, distinguished from misinformation and disinformation as being information that's not attributed to any particular source. It's just sort of out there in the ecosystem, in the ether of life. And so there is that. And sometimes rumors are true, sometimes they're false. But that is also a third category that is a smaller piece of the puzzle. Mm-hmm.
Well, we're all familiar with misinformation and disinformation around COVID vaccines, but can you share some other examples of public health or other medical and health research issues that have been subject to misinformation?
If that's headed to me, I think one of the most common examples that I think we all can appreciate would be the Tuskegee syphilis experience, where there, because of the horrible insult that was done up until not too many years ago, there is this sense that that the American research infrastructure is untrustworthy or unfriendly to people of color, and that it is very easy to be abused even today, similar to the insults of Tuskegee. That transcends a number of elements, but the idea that somehow that the research enterprise in this country is one that is willing to deliberately harm individuals is a very pervasive challenge that we continue to face in a variety of areas.
Any other examples, Ross or Claire, that you want to offer?
What? Go ahead, Claire.
I was just going to say, I think almost any issue, any health concern, if somebody gets a diagnosis on whatever they've just been diagnosed with, they will go online seeking information and they will find some accurate information, but they will find a lot of other information, often people trying to sell alternative treatments or weight loss or whatever, you name it. And I think that's the problem. We have obviously fixated on COVID and the vaccines, but we've had problems with health misinformation for a long time.
Yeah,
Ross, would you concur?
Sure, I would concur. So while I was a clinician, a lot of what I dealt with was Lyme disease. And Lyme disease is a disease that is fraught, particularly extended Lyme disease, is fraught with misinformation, mistreatments, and in fact, some of it's very unscrupulous. It's people who know what they are doing doesn't actually have any benefit, but since they're making money at it, they're not going to think very hard about that. They're going to keep infusing those antibiotics, making money, and even if the patients don't benefit, in fact, they continue to feel bad and crummy getting the antibiotics. They keep getting it because the physician providing that treatment is making money off of it. So we've had unscrupulous care, unscrupulous information, and going along with that, lots of diagnostics that were inaccurate, because if you're going to offer this extended treatment, it's really important to diagnose it. So you got crummy diagnoses going along with bad management, providing ineffective care for people who really are sick. I mean, that's the other thing. Chronic Lyme disease is a real disease. It's just that the treatment being offered is not a match to the disease itself.
And of course, Jenny, we have the other challenge that so many of us are facing right this moment, and that's for routine preventable childhood vaccines. And again, the idea that being vaccinated will cause your child to develop autism and other horrible sequelae that certainly are not supported by the literature. That is one that just simply does not go away very easily. And we even see someone who's making millions and millions of dollars and running for president, a guy named Robert Kennedy Jr., who's getting a lot of mileage out of that misinformation, that deliberate disinformation.
Yes, absolutely. So Claire, you indicated this notion that we need to look beyond kind of traditional definitions of mis and disinformation. Can you say a little bit more about what we've learned over the past 4 years? I mean, there was so much mis and disinformation involving COVID. What have we learned? What have researchers learned that will help us as we move forward?
So I think the first thing we need to realize is this is not a case of needing more facts. I still hear people say, we just need to get more facts out there. And we need to realize that people have an emotional relationship to information. We all do. We react to content that makes us feel something. And I think the saddest part of COVID was seeing how topics around health became politicized. So when people talked about their position on ivermectin, that wasn't necessarily about facts. It was because they were performing a political identity. And that's what makes this so tricky in terms of how we're trying to help people navigate this, because they are performing their identity and they're feeling connected to community. And so I think one thing we have to recognize is I think those of us who live, we're researchers, we're doctors, we're journalists, we still think about communication in a top-down, hierarchical, linear way. The person with the most letters after their name will stand at a podium. Actually, if you spend time with QAnon believers or anti-vaxxers, they actually are networked. They feel like they're being heard. They feel they can do their own research. They feel they have agency. And of course, there's problems with that. But we have to learn, I think, that this is not simply about the person with the most letters after their name giving more facts. It's about how people are feeling, how scared people are. And when they're scared, they're seeking answers. And so I think that's our biggest lesson over the last few years is, well, I think we've learned a lot. I don't think we're acting in a way that we need to, which is to really respond adequately to people's fears and make them feel like they're part of the solutions.
Claire, it sounds like you're touching on, Reed, if you can hold just for 1 second. It sounds, Claire, like you're touching on some themes that in an article that you wrote, which I think the team will put in the chat. You wrote an article this spring in Issues in Science and Technology, and you wrote about the difference between studying what you termed atoms of content rather than narratives. Can you say more about that? I think you were starting to go in that direction. And
yeah,
perhaps
so
if you can talk a little bit more about this, the role of community.
Yeah, so I think as researchers, we have databases and we go online or we do surveys and we collect examples. That you started this. Can anybody think of an example of disinformation? And oh, here's a meme I saw on Instagram. Here's a YouTube video. And we collect them as if they're standalone problematic pieces of content, when actually people understand the world through narrative. So Reed talked about the ongoing impact of the way people trust the health industry because of the Tuskegee experiment. That's a narrative around trust that people fit into that. Globally, there's huge narratives around depopulation and the idea that the West is trying to use vaccines to, I mean, these are the bigger narratives around who to trust, who not to trust. And so when somebody sees something on Instagram, it sits within those overarching narratives. But it's harder for us to think about narratives as researchers. So we play whack-a-mole with the individual posts. And that's getting us nowhere. We need to zoom out to say, well, how do people make sense of the world? And they often make sense through their communities, through their lived experiences and histories. But again, many of us who think about science aren't anthropologists. And so our disciplines need to come together, because at the moment, we're not talking to one another. And those skills are so important for understanding this moment that we're in. So,
Reed, this gets to a community-based approach. So Claire's talking about the need to build resilience within communities and the importance of recognizing how communities function around misinformation. The Black Coalition Against COVID strikes me as an example of an approach that was very community-based and also quite successful in addressing misinformation, as well as other issues in fighting the impact of the COVID pandemic on the Black community. Could you say a little bit about the work that you did on misinformation?
Terrific, yes.
That effort?
Yeah, but let me quickly just come back to just to hit one of the main points that Claire made, which I think is just so exciting and what kind of got me enthused. And that is the challenge of all these names with titles behind it, living in and trying to participate in a world now where so many Americans distrust elites. And so the very nature of our titles is harmful in many ways to the conversation. It seems very perverse. But there is a growing movement in America to be anti-elite, and our science and our medical leaders are considered a part of that. So it is a very difficult challenge. I think that what the Black Coalition Against COVID work that we did was to unite the Black community's medical leadership with the community itself. And so the Black Coalition Against COVID was comprised of the 4 Black medical schools, Howard, Meharry, Morehouse, and Drew, the National Medical Association, the National Black Nurses Association, the National Urban League, and the largest publisher of digital health information, blackdoctor.org. Together, we were able to partner and bring to the Black community not only the expertise from trusted physicians and nurses from their own community, but also to partner those physicians with the faith community and our social and fraternal organizations, so that we all came together as kind of one group. And then we would have presentations. It would be the physician sitting beside the pastor, and the pastor had an equal role with the physician or the nurse. So in other words, and then having like all the sororities and the fraternities all a part of that. So we began to see a combined community ethos. And the point that I'll end with on that, Jenny, is that there is a very real problem that COVID pointed out, which is a disconnect, but or a lack of commitment to what used to be a given, the fundamental humanizing ethic of respect for life. That was very, very powerfully eroded. This sense that no matter what you're doing, that the death of 1 million people matters. That ought to mobilize us to action. And in fact, what we saw with COVID was it didn't have a lot of impact on a whole bunch of people in this country who had other issues, which we just sort of heard about a little minute ago. Other issues, the socio-political issues, being more important than whether or not people lived or died. And so for the Black community, when we had adopted the slogan, Black Lives Matter, we had to basically come together and say, well, if Black lives matter, and they do, then they have to matter to us first. And we certainly learned our lessons in America that it is very difficult to expect the nation to come in and save our lives unless we do the work we have to do to save our own lives. And so by bringing all of that together, we hopefully created a sense of urgency, a sense, as we use the word agency, a sense of we are in it together collectively, and we are ultimately in this because we are tired of dying at so much higher rates than everybody else.
Well, Rita, I'll say that, and for people who want more information about the Black Coalition Against COVID, we'll put a link in the chat, and there's a report that I think really documents all the work that you did. But you, over time, the rate of vaccination among Black Americans rose to that of white Americans, in spite of loss of access and other challenges.
And the key thing there, Jenny, and I'm so glad you raised it. So not only did we have to run a race with an anvil on our back, and we got a very late start out of the blocks, and because the programs, especially when there was scarcity for vaccines, was not very easily available, despite all of that, we were able to mirror, and for the first time close completely a disparities gap. But here's the issue. What was exciting about that and important is that when you look at life expectancy the second year into the pandemic, Black life expectancy from the pandemic was better than white America. This has never happened before. And so what that does tell us is that it is possible to some degree. Now, I don't want to overstate this, and I'm not overly Pollyanna on this, but to some degree, it is possible to overcome misinformation, disinformation, distrust, and make a difference. And that ought to embolden all of us to redouble our efforts going forward. This is not hopeless.
Thank you, Reed. Thank you. Ross, AAMC has been working with a number of your member institutions, academic hospitals around the country. You've gotten some CDC and other funding, and you've been doing some really, groundbreaking work at the local level. Can you share a few of the examples?
Well, the goal of the program, it's a CDC-funded program called Vaccine Voices, is to try and provide credible information that reaches communities that may not have been listening. And a lot of what we have to look at is these communities we have are separated. There are those who are never going to believe anything they hear from an establishment source. There are a lot of people who are just looking for answers. And for some reason, they find the more credible sounding answer is coming from what we would not view as a credible source, but they're perceived to be because they're looking for answers. And then there are the people who look to us historically and continue to look to us historically for information, which is still a majority, but it's not everybody. So how do we reach the in-between, the people who are interested in finding answers? And so part of what we did was to actually speak to them. So a lot of the Vaccine Voices project was talking to media sources that were not the usual ones. So I did a lot of talks on Fox News stations because that was the sort of people we thought needed to hear other voices. And it was always, to me, it was interesting. The reporters nearly always said, oh, what you're saying is just correct when we're off the mic. But on the mic, it was totally different. But off mic, they actually wanted to hear what we had to say as the credible medical people speaking to the community. So it's important to try and find the people who are looking for information, that are open to information from the kind of people that we reflect, the research community, the medical community, and to value that trust and to listen to them and what they are looking for, because that communication is critical. You need to answer the question that they are asking, not the question that you want to answer.
Mm-hmm. Well said, well said. What can hospitals and health systems do to support their staff in responding to misinformation? Ross, let's start with you, and then Reed and Claire as well, you may have thoughts on that.
Yeah, well, what a hospital or a medical school can do is to provide people who have information and provide information regularly, talking points, and to be a conduit. So, for example, the ID people, I worked at Duke for years. Part of their job was to hear what was the concerns that were coming out of the community and to provide answers back that the staff could use. Also, given the way things have gone lately, you have to provide security. You have to be aware, but it's key to be listening to the community at large, and the institution can be supporting that by doing outreach into the community, by going to different parts of town that may not perceive the castle as the source of information for them, but they might be willing to hear a session with a pastor and a doctor in the community. And so I think it's important to support the people in the clinic by providing information in a way that's accessible to the community.
Reed, any thoughts?
I think in addition to those excellent points, number one, the most important thing for me is treat every single patient with dignity and respect. That we have got to turn this issue of lack of trust in the health system, we've got to turn that around person by person. And every time we disrespect someone, that is someone who is now ripe for being a receptacle for misinformation. The second thing, what I think Ross got is very important, is listening. That is so key, learning to sit and listen to people instead of, and hear where they are coming from, and then deal with them based on that, as opposed to that finger wagging thing, which we are so good at. That doesn't work anymore, that finger wagging stuff. That was Marcus Welby era. This is a different time. And then I think the third thing is we've got to start to do, and I'll be happy to see what Claire says. I think it is important that we start to train people about what words to use, how to have the conversation. This is an art form. And Ross knows from his work at AAMC, we teach the art and the science of medicine. And so, Claire, I would think that the art here is very important.
100%. There's actually a lot of empirical research about how effective motivational interviewing is, which of course many clinicians do to help their patients think about what prescription drugs they might take. But it's all about empathy. It's all about listening. And I just want to really emphasize what Ross is saying, which is there's a lot of headlines. There's a lot of funding that goes towards what I talk about as like the 20% of the information ecosystem, the worst of the worst conspiracies, the Bill Gates' microchipping. Actually, the people who deeply believe those things, they do, but they're relatively small, and it takes a whole host of other interventions to pull them back. 80% of the information ecosystem is people having really valid questions. But if we don't answer those questions effectively and quickly, then we create these voids that then get manipulated by conspiracy theorists. So people like, I'm seeing athletes dying on the sports field. Why? well, if we're just not saying anything because we don't have enough data, people start to, what's myocarditis? I don't know. My Uncle Bob says this. By us not saying anything, we're creating more problems. And that's obviously a huge shift in science, because we don't like to say anything until we know something absolutely. But we've got to be much more humble in our communication about, this is what we know right now. We're doing everything we can to protect you, et cetera, et cetera. And so that's a shift. But I think exactly what Ross is saying, how can we listen effectively to people's questions? Because if we did a better job of that, we would have, I think, fewer people who then become more susceptible to misinformation. And whilst it's easier to blame the conspiracy theorists, we, as in researchers, journalists, clinicians, we have a lot of agency in our part of the information ecosystem that we can control. But that's a mind shift in terms of, at the moment, misinformation is, other people cause that problem. We all play a role here in improving the information ecosystem.
So, there's quite a growing grassroots movement to train folks in the research and science community to be better communicators. A 2022 global study of researchers by Economist Impact and Elsevier found that less than 20% of researchers had a lot of confidence in their ability to communicate their findings or to communicate at all on social media. And in fact, researchers in the US reported the greatest amount of harassment online. Since social media is a key way that folks are sharing and getting information, should we be training researchers, scientists, clinicians to do a better job with social media? Is that a valuable investment?
Well, I'd say all forms of communication. So yes, social media, but also how to talk to people. And I think too much of this problem, there's a disproportionate focus on online, but Reid started it off by talking about rumors. It's what's circulating at the local bar, what's circulating at the school gate. That in itself is a real problem.
I think the other concomitant challenge here is, if I could ask the healthcare research and medical care system to do one thing, it is adopt the Secondary Science and Math Teachers Association in your city. We have a complete mismatch between the growing complexity of scientific engagement, of medical care delivery, and the science literacy of the public. We are moving inexorably forward in a genetic-based world with probabilistic statistical decisions everywhere that we turn. We're having mRNA vaccines that are moving through as common now as anything that we're doing. And yet the public is unprepared to participate in this fundamental science. And so if we continue to allow our school systems to graduate young adults who are completely irrelevant to the understanding of the science that will affect the largest proportion of activities and financial costs in their lives, maybe save for their house mortgage. Other than that, we're going to continue to have a problem. So we can ask the researchers and the clinicians to work hard to communicate, but if they're talking to people that don't understand what a virus is or what is a mRNA, we're going to have a much harder time. And so let's get up there and start to deal with the root causes of some of these problems and stop trying to treat everything secondarily.
Thanks, Reid. That's a very important point. So we've got a few audience questions. Reid, I do want to save a little time at the end to talk about the Coalition for Trust in Health and Science that we've both been involved in. But before we do that, Sarah, do you want to jump on and pose the audience questions? Thank you.
Yeah, thanks for that. And thanks for the great conversation so far. We have one question here. Techniques like pre-bunking are talked about as approaches to misinformation. What is pre-bunking and is it effective? I guess that could be answered by most of you, but.
I'm happy to jump in. We've just done a big literature review on interventions that work around misinformation. And so just to explain what pre-bunking is, it's about teaching people before they see misinformation, the tactics and techniques that might be used against them, how their emotions might be manipulated, the idea that just because somebody's wearing a white coat, that's a known tactic. So just be aware of it. And so what the science shows is that the more you train people in the knowledge of the tactics and techniques, they're less likely to fall for misinformation when they see it. And this actually works irrespective of your political persuasion, because as humans, we don't want to believe that we're being manipulated. So when we teach our nanas not to get scammed through what's in their mailbox, by teaching people to be beware of that kind of material, it works. So there's been some really good games that have been built and other ways that you can pre-bunk. Some of the platforms do it, but that's actually more effective than debunking, because that's after the fact, and too much that gets caught up with people's confirmation biases, and people want to resist the debunking because it's about the content, whereas pre-bunking is about the tactics.
Thank you, Claire. Sarah, I see a question that I'm going to pose, and it relates to something that Ross and I discussed in getting ready for this. So what can be done when doctors and researchers counter the science on repetitive head trauma for kids in sports because of their ties to football organizations, ostensibly? But this gets to the broader issue of what do we do when folks who have the credentials are deliberately, and I'm not saying that's true in this case, but deliberately spreading misinformation. Should they be sanctioned, punished by the medical community, the regulatory boards that oversee their work?
Well, I'd say there are two parts to that. If something is known to be a fact, if we've already worked it out, and it's known, and somebody is continuing to speak against that. Say, for example, ivermectin, and they advocate for the use of ivermectin for the use of COVID. We know it doesn't work. Politics it doesn't matter. It just doesn't work. And so advocating for that. So should we consider sanctioning a doctor who continues to harm people by giving them a medicine that actually does have side effects and is known not to work for the disease? And I think that's very reasonable. I think you begin by first trying to educate them to make sure they really do understand. And if they're doing it for the reason that it's most likely, they're making money off of it, they're unscrupulous, then I think sanctions are reasonable. And we have seen sanctions used by some of our boards and other regulatory agencies. And I think it's appropriate. Where somebody doesn't know, where something's a gray area, and that's a different matter. For example, we still, there's some grayness around the use of plasma or monoclonal antibodies work, but plasma, probably it's marginal, but there's room for debate, and there is still scientific debate. Then the only thing you could say is you wouldn't want somebody saying that something is a fact that is still a question, but that's a different matter than saying that something is true that is not true. And I think the latter is sanctionable. The former, the one where it's still in a gray area, you just encourage them to accept what they know and don't know.
Jenny, I think Ross really answered it well. Let me push the envelope a little further, though. I think one of the challenges that we collectively have is the ability to define in real time what is truth, what is evidence. Should I wear a mask or not? What do we know about that in real time? There's so many of these issues that occurred that even though we had a pretty good sense, there was no certifying body, for example, that says, well, this is the actual, we come together and we agree that on Wednesday at 2:00, from this point on, these are the facts, and anything outside of that is misinformation. So how do you do that in real time? Because this was what caused the lawsuit in California, where the bill that they tried to have in effect to actually sanction people in California was obviated because we had that challenge. So I just think that all of us in science and health are going to have to tackle this one now, get it right, and figure out, when do you say we know, and when do we say we're not sure? That gray area that Ross says, unfortunately, can be applied to a lot of things. And so we got to figure out, how do we deal with that in real time?
What is what is the Coalition for Trust in Health and Science doing to help the medical and research and clinical community deal with these issues?
So the Coalition for Trust in Health and Science is now 90 organizations representing, for the first time in history, the entire health ecosystem, end to end, is now joined together in a statement to the American people that says this issue of trust and misinformation is so key to who and what we are as individual clinicians, health prevention experts, or organizations. This is so fundamental to who we are that we have to set away whatever differences we have in terms of our normal business and come together on behalf of the best interests of the American people. And so what it is trying to do is to collect the entire intellectual firepower of the health ecosystem, whether it is the basic scientists at AAAS, whether it's bio and pharma, the hospital associations, all the medical societies, nursing societies, pharmacy societies, ethics institutes, telemedicine. So to conclude it, what we're all trying to do is bring it together and bring in smart people like Claire Wardle and many others who are very bright, people who are outside of medicine, who are struggling with misinformation, the people that are experts on social media and misinformation in the news. We have so much that we can learn together. And what we're trying to do is become a learning laboratory so that everybody can benefit all together, and we teach each other best practices on behalf of the American people.
Thank you, Reed. Clearly, there's a lot of new findings in the research community that still have yet to make their way, right, to those in medical practice or in medical research. And so that's in part, I think, what the coalition is so important for the coalition to do. We are coming to a close. And so I'm going to ask each of you to share thoughts for our audience of advocates, researchers, practitioners, et cetera. What should they do? What can they do in dealing with what often seems like an overwhelming situation? Ross, let's start with you.
I think that they can continue to work on listening, hearing what are the rumors and concerns that are circulating so they can address them directly, and communicating with the people and communities that they serve so that there really is a dialogue going on. I think the best point from my perspective that I said today is, you have to truly listen to the people you are trying to provide information to, so you're answering their questions. That's what we all have to do. And it's an individual thing as well as where we have the opportunity to speak to larger communities.
Reed?
I will walk the same road that Ross did and just take it a step further and say that in that conversation, we have to, with every act, every bone in our body, every fiber in our being, help to people to understand that there has to be respect for life, that whether we live or whether we die, or whether we suffer from preventable and unnecessary illness is a matter of the highest priority for me as a clinician, for me as a researcher, but it has to ultimately be for us as a nation, and that everything else has to be secondary to that. We've got the horse before the cart, and we got to get that fixed.
Claire?
Yeah, and I'll just build on that too. I've been studying this for over a decade, and too many times people go, oh, it's just some nonsense on YouTube. How is that even a subject to study? But it is fundamentally impacting every issue that we care about. So I think my lesson to everybody is there's no silver bullet. We're not going to get out of this quickly, but we do have to take it seriously and not just mute Uncle Bob on Facebook. It's about having conversations with people and recognizing that there's this drip, drip, drip effect. All these tiny Instagram memes and YouTube videos are meaning that people have declining trust in institutions that they need to rely on in moments of emergencies. So yeah, just take it seriously. But you're on this webinar, so I think people already are. So that's good.
And we need to also, and I think this is embodied in what each of you have said, is continue to really engage with those who are outside of the public health community, outside of the medical community, outside of the scientific community. Really try to close those gaps. So thank you all, really appreciate it. What a terrific panel. And now I'm gonna turn things over to Derek. Thank you, Derek.
Thanks, Jenny. And thank you, Reed, Claire, and Ross. I really appreciated that session. It was enlightening, certainly, for us to gain some basic understanding of the issues, but at least as importantly, and I think really inspiring, was that you gave some real reasons for us to believe that the situation is one that can can improve, that people can come up with real solutions, because you all have, and you will continue to do so. So thanks so much for that. So to everyone, we have a break now for, I guess, about 9 minutes or so. Please be back in the lobby starting at 1:10 Eastern time. The next session is what happens with my data in health research. So I'll see you in the lobby in 9 minutes or so. Thank you.